a pediatric occupational therapist.
You ready?
Yeah. A little bit more about me. I'm also a wife. My husband and I will be celebrating 12 years at the end of this month. And then our oldest is Lucas. A bit about my professional background. I have a bachelor's in health sciences and a master's in occupational therapy. I have a very strong background in the medical field because I intended to go to med school when I was younger. Then I fell in love. But then I worked in pharmaceutical research for a while also. So I'm very research heavy when I look at these things for my kids and then our community now. Before I get started on the actual topic, I wanted to share a little bit about why I even started this. So a couple of years ago, we noticed that for my child, for Lucas, we were having difficulties with learning, and it was just more than just learning difficulties. We were having emotional issues, also with regulating emotion, and just a ton of stuff. We started him on therapies speech and occupational therapy, just because we were already doing it for middle, so just got another one in, right? And I realized that what was happening, we weren't really addressing super bottom up for him in therapy, and that didn't sit well with me because I understood neuroplasticity, and I felt like if we've got amazing neuroplasticity at this age, why are we not building on that instead of teaching skills and creating compensations, basically? So next slide, please. So how many of you have heard about the pyramid of learning? Yep. Okay. So the pyramid of learning is a framework that shows how child's ability to learn and behave and function are built on foundation of sensory and motor development. It was developed by 2 occupational therapists to help explain why higher level skills depend on lower brain centers, on lower level brain and body functions. But when you look at the pyramid, you can see at the bottom is we have your central nervous system, and then we have sensory system, sensory motor, perceptual motor, and cognitive. So it all builds up to cognitive function, right? Executive functioning. What happens in traditional therapy models is that we're addressing all the sensory stuff, at least as OTs we are, but we're not really addressing the central nervous system. And oftentimes, gaps in the central nervous system will not allow, you're leaving gaps there, and you're building all these other skills going up, and they're now we're building compensations instead of really trying to build that firm foundation for a learning later on. So for the next slide, this is how I address neurological organization in my practice. So what I do first is I explicitly address primitive reflexes, then vestibular system, that's your balance center, that builds your balance, your coordination. Then we build ocular system, and then we build your cognition. The reason why I feel this is helpful to do it in this order is because a lot of times I'm getting kiddos that are far beyond that age of that prime neurological development for neuroplasticity. So you have to be intentional with what you're doing at every step to rebuild that essentially. So my purpose tonight is to be able to explain some primitive reflex patterns and what to look for, because unintegrated reflexes do present with certain signs and symptoms that you could easily find in a child. So before I get into primitive reflexes, I'm a visual learner, which is why I've got a ton of pictures on here. But I wanted to first go over a little bit of basic anatomy that when you hear me say this was here, you'll know. So the yellow part is your brainstem, and then you have cerebellum. All primitive reflexes start in brainstem, and then they feed into cerebellum by the time that your baby is born. Cerebellum is very small compared to the entire cortex of the brain, but it has the most neurons, so the most brain cells when compared to left and right hemisphere. Then we're looking into higher cortex. You have occipital lobe, that's your vision centers. Parietal lobe in the blue is responsible for sensory and motor information. And then your temporal lobe is where your speech centers are located. And frontal lobe is all your executive functioning. So all of the things that we want our kids to be able to do for independent living are coming from that frontal lobe. So primitive reflexes, what are they? So primitive reflexes live, like we said, in the brainstem and cerebellum, and voluntary movement patterns that all babies are born with. So they originate the brainstem, and so as the brain matures, these reflexes should integrate and they should be replaced with more voluntary movements. So what's happening essentially is when babies, we have the reflexes, like the most common one is rooting, that babies can easily go like this when baby turns and they're looking for feeding. The more stimulus that you provide a reflex, the more it'll start feeding up into higher brain centers. So it goes from midbrain, from cerebellum to midbrain, and then frontal lobe. The whole point of that process is so that to allow maturity in the frontal lobe to be able to override a reflex. Is this making sense? Is this too nerdy? Okay. I'm trying to keep it as plain. Yes. So the next slide. Sensory versus foundational reflexes. This is the way that many courses categorize reflexes, just because some go away faster than others, and also just the purpose of them all. But sensory reflexes are these automatic movements, again, that come from sensory input. So these would be something called the Babinski reflex, your spinal Perez, Rudy, and Palmer. In Down syndrome, I'm finding Babinski no matter what age. Babinski indicates an immature nervous system. And in adults without Down syndrome, when you have a Babinski, it indicates an upper motor neuron lesion, so some days, which is not a good thing. Foundational reflex, these ones are early automatic movement patterns that form the foundation for advanced movement, posture, and coordination. These ones are my favorite to work with because you're essentially rewiring the brain to gain functional movement patterns that we use from day to day. Next slide. So I'm going to go over each reflex and explain the signs and symptoms associated with these, so that you as parents could know, and if you feel like any of these are a thing, you can do a little bit of research and find out some ways to help. So the first one is Babinski. We find that one in our feet. And so this one emerges, meaning it starts to come up while baby's in utero, and it's completely present at birth. It integrates between 12 to 24 months. So integration meaning, again, it gets overridden by frontal lobe to more purposeful movement. Signs and symptoms associated are, we often see kids toe walking with this one, and we have abnormal gait pattern, which is a thing with Down syndrome, also the abnormal gait pattern because of low tone, right? Spinal galant is the next reflex. This one is a spinal reflex that was located in the back. It emerges at 20 weeks in utero, and it integrates 3 to 9 months. Signs and symptoms associated with this one include lots of fidgeting. We have difficulty sitting still. It affects learning for that reason. We often have sensitivities to our lower back. It affects postural stability and control, so ability to sit up straight. And we have delays in gross motor coordination, and oftentimes cases of bedwetting when the kids are older, also with this one reflex. This reflex will get your child misdiagnosed with ADHD. There's a high retention rate with this one as well, in Down syndrome. Next reflex is spinal Perez. It's like a cousin to spinal galant. This one emerges at 20 weeks in utero, and it also integrates between 3 to 9 months. We have some symptoms that include postural control, so again, being able to sit upright, challenges with self-regulation, emotional reactivity, or irritability. I've seen kiddos elicit this reflex when we're at therapy and we are asking them to do something hard, they will that's spinal Perez. So we have to, for sensory reflex, the treatment would be desensitization. Rooting reflex, that's the most common one that we all know. This one emerges while in utero at 28 weeks, and it's fully present at birth as well. It integrates 4 to 6 months, and challenges with this one include speech articulation, constant oral seeking behaviors. I would even argue oral motor for our kids. And the last sensory reflex is the Palmer reflex. This one one emerges at 16 weeks of gestation and is fully developed at birth. It integrates 5 to 6 months of age, and signs and symptoms associated with this are weak and immature grasp patterns, difficulty releasing objects, limitation in hand manipulation, and difficult with bilateral coordination. So as an OT, I see that, and that is like my goals for any client who has this reflex. So fundamental reflexes. This is where I have the most fun. I get a little nerdy when I talk about these, and I tend to talk fast, so if I talk quickly, just I'll slow down. But the first one that I want to talk about is Moro. When you read on a reflex, and a lot of books say we need to treat Moro first because it's responsible for flight or flight. Yes, but no, it is responsible for flight or flight. But I treat all the reflexes together in one. I don't believe like singling them out is going to do anything, just because naturally when we go through a normal neurological progression, we don't do things in order for each reflex, we just do it all. Moro is responsible for keeping your body in fight or flight. So with your central nervous system, we have the parasympathetic and the sympathetic nervous system. One is responsible for your rest and digest, so it slows your body down, versus the other one is responsible for keeping you alert and fight or flight in case you've got to run away from a lion that's chasing you. This one emerges at 9 to 12 weeks in utero, and it's fully present at birth. It gets integrated by 4 to 6 months of age. Although it becomes integrated, it doesn't fully go away because we still need access to that fight or flight in case of an emergency. So this reflex matures into a startle reflex in all adults. I would argue that this reflex has two components. It has a vestibular and an auditory component. So vestibular stimulus can put you in fight or flight, and also auditory. So think about our kids who have like sensory processing with loud noises, that triggers their Moro, or kiddos who have gravitational insecurities, that triggers their Moro as well. So some signs and symptoms with this one, we talked about tendency towards flight or flight. We also have poor focus and distractibility, emotional outbursts or quick mood shifts, difficulty with routine shifts, and may appear controlling or rigid as a coping mechanism. Which a lot of our kids have OCD tendencies, so yeah, yeah. ATNR, this is the asymmetric tonic neck reflex. This is my favorite reflex to work with because it's tied to so many functional skills as an OT. And when left unintegrated, it also is tied to so many diagnoses, like definitely autism, yes, but ADHD, dyslexia, all those like other neurodivergent diagnoses that aren't necessarily from genetics. This reflex emerges at 18 weeks in utero and is fully present at birth. Typically, it integrates by age 4 to 6 months. Some signs and symptoms with this one are difficulty with crossing midline, which is also very commonly an OT goal, poor handwriting, poor bilateral coordination, auditory processing challenges, and difficulty with visual tracking. So think reading, right? It's difficult for kids to be able to read when they are not able to track. And then, of course, that's visual motor integration. Next reflex is STNR, or symmetric tonic neck reflex. This one emerges at around 6 to 9 months of age, and it integrates 9 to 11 months of age. There's a high retention rate of this reflex in our kids with Down syndrome, and to me, it comes down to core with this reflex because some of our kids are very low tone. We know that low tone doesn't necessarily mean that they're weak, but you have to be able to activate muscle to strengthen it, right? And so with low tone, we can't really activate muscle really well. So we try our best to influence tone and build core to get rid of this reflex. Some signs and symptoms associated with it are poor posture and core stability, poor coordination between upper and lower body, and they usually appear awkward with movements involving half of their bodies, and visual motor integration as well. The next reflex is TLR. This one also has a very high retention rate in Down syndrome. Typically when I do our intensives, this is the reflex that I'm hanging out here for a little bit after intensives, just to continue to build core and make sure this one goes away. There's two positions for testing in this when they're infants and adults. We can just stand up and do the testing, and we move head back and forth to determine the read on that. But typically you will see that they become very fatigued when sitting. They can't hold their body up because they're just so weak. And that weakness doesn't allow for integration of the reflex. And we also have poor balance, gravitational insecurities, organization and spatial challenges. We are sensory seekers a lot, specifically vestibular system. Vestibular is your inner ear system that does balance and coordination, and our visual motor integration. So our hand-eye coordination is a little bit off also. So reasons for retained primitive reflexes in Down syndrome. So before I go down that list, I also wrote this little quote on the side that retained primitive reflexes are not the problem. They're a clue of what's happening in your child's brain. I wrote that down because it's a reminder for me as well. When I started researching this topic, I remember thinking, if I could only integrate Lucas's reflexes, he would be more neurotypical. And that's not the case. Integration of reflexes just allows for better foundation and easier learning later in life. But typically, if they're there past a certain age, that indicates something else is going on in the brain, and it typically will point to just an energy problem in the cells, mitochondria. So we're going to talk about that a little bit later. But before I get into that, some reasons why retained primitive reflexes occur in Down syndrome are low tone. So with low muscle tone, it's a hard one because you can't, there's only so much that you can do to influence tone. Tone lives in the cerebellum, and we know through research that in the cerebellum, the kids with Down syndrome have less amount of neurons than kids without. So doing other things, providing sensory input from the body out will allow you to influence that in that way, and also building tone, so explicitly building core. C-section births also cause primitive reflexes, and this is not only just for Down syndrome, but across the general population. Missed or delayed milestones as well. Neurological insult, so meaning trauma or injury. Not only physical trauma, but emotional trauma also will get kids to rewire somehow. I don't know how it happens, but I've seen it in Down syndrome where there's an event that happens in the family, and all of a sudden we're regressing, and that has to do with trauma. Trauma also can present as autism. In cases of Down syndrome regression, also we see the presence of primitive reflexes. And research also indicates that unintegrated reflexes are also found in kids with autism. And I wanted to write that in there because I know we have several kids in our community with dual diagnoses, and so they already have those two things against them when it comes to retention of reflexes. And so in Down syndrome, we know that we have mitochondrial dysfunction already due to the overexpression of the genetic material, right? So we have increased oxidative stress, and we have a more permeable blood-brain barrier. So those things already make our kids a good candidate for low-level light therapy, just because they add up to mitochondrial dysfunction. Before I get into more of the low-level light therapy, I wanted to show another visual of the human cell and kind of show you the parts where that's targeting what we're targeting when we do low-level light therapy. So in the human cell, we have multiple organelles, but the one that matters for low-level light therapy is that orange one called the mitochondria. We will have multiple of those in one cell. And The whole purpose of it is to create energy for the entire cell, and it helps regulate inflammation and oxidative stress. There's well-documented literature indicating the presence of retained primitive reflexes exists in kids with neurodevelopmental diagnoses, including Down syndrome, CP, and other genetic conditions. And this is because the mitochondria and these neurons are not producing enough energy to efficiently activate these brain centers. There's also documented literature on that. We can solve this energy crisis through low-level light therapy. Low-level light therapy. It's all. Do you want to do the next slide?
Okay, thank you.
Transcranial photobiomodulation. So who has seen red light panels? Yep. So essentially, it's a device that will do red light therapy, but it's not like the panels. So photobiomodulation is the utilization of non-ionizing electromagnetic energy to elicit a photochemical change within the cells. And particularly, the mitochondria is very receptive to the photons at specific wavelengths, and that helps increase energy in the cells. So photo means using photons, bio, cell function, modulation means influencing, changing, or normalizing and stabilizing. What's important to note here is the non-ionizing part. I recently had a question about radiation with laser therapy, and non-ionizing means Derek could best explain this because he did X-ray and CT, but you don't get radiation from non-ionizing electromagnetic energy. All right, next slide. So some of the benefits of low-level light therapy or transcranial photobiomodulation. There's lots of research on use for the body, and there's emerging research for use on the brain. There are already articles published, and I know there's a couple right now that are occurring specifically to Down syndrome as it relates to speech. But some of the documented benefits that we already know about are increased blood flow, reduction of oxidative stress. So it also promotes angiogenesis, which is the growth of new blood vessels from existing blood vessels. It inhibits neuronal inflammation, which we know exists in our kids also. It inhibits apoptosis. Apoptosis is the brain's immune system. I feel that regression happens from apoptosis because what's happening with apoptosis, normally I'm trying to explain this. Okay, so just like our body has an immune system, we have an immune system in the brain. The cells in our brain also go through a cycle where they die off. When there's an excess of cells dying off, then we're now losing brain connections, and that's apoptosis. When they die off faster than what they're able to connect. And so that happens, that's where regression comes from. That's where Down syndrome regression comes in. We also have increase in neuron progenitor cells. These are like the stem cells of your central nervous system. It also promotes neurogenic secretions. Think of your brain-derived neurotrophic factor is the most common one. And these are specialized proteins that act for survival and differentiation in the nervous system. And then we know it also is beneficial for synaptogenesis, which is the creation of new pathways. So what you need, the most common question that I get asked when people first inquire about laser therapy is what's the difference between LEDs and lasers? So laser is an acronym for light amplification by stimulated emission of radiation. And this is light created in a way where it's collimated or coherent light versus LEDs is non-coherent light. So what that means is the top picture is coherent light. So it travels linearly and it's tightly packed together for deeper penetration. versus LEDs, which are non-coherent. They scatter once they leave the diodes, and so you cannot get deep penetration transcranially for that. It's great for use on body. I actually do suggest for my clients, just get a red light pen. When you ever get sick, sit under it for a while. It's good stuff. But unfortunately, it cannot be used transcranially, because when we use transcranially, we have to take into account the deep brain structures that we're trying to target. And then we have skull thickness, which is different in every area of the brain. And then we have different layers also. So additional considerations for transcranial photobiomodulation. I put this on here in case anybody had questions about just any further questions, but things that I look for when I'm looking at a laser are power output. That's measured in milliwatts. And typically for power output, you want a higher power because it means more delivery per second. However, effectiveness doesn't depend on the wavelength, and effectiveness does depend on wavelength, dose, treatment time, and the depth of penetration, so where you're trying to target essentially. Wavelengths. So the wavelengths are the different colors that you see when we utilize the laser. And these wavelengths, what they mean is how deep the light can actually travel. In my practice, we have green and purple, red and infrared. So you can see how deep they actually go. Infrared is the only one that can penetrate really deep. It says bone and joints here because I couldn't find a good model for transcranial use, but we can definitely get to deep brain structures, which I'm often targeting. Next slide. So the device that I use is called an Avant LZ30 Pro. It is FDA cleared. It is a class 3B medical device. It has amazing power density, allowing me for little treatment time and more time for stacking other interventions when I'm treating. I put the specs on it just in case anybody had any questions on that. I really do like this device because I feel like with lasers, there's multiple on the market. This is the most affordable one for what you're getting, and treatment time is very little. A lot of times I'm treating kiddos that are moving all over the place, or we're trying to do an exercise, and I like stacking interventions because I'm stimulating a brain area while I'm providing energy to it also. So it just works. I'm able to treat one area for 2 to 3 minutes and I'm done, and I move on. Next. So when's a good I keep changing it on here. So when is it a good time to start? So I would say now. The question of neuroplasticity pops into my head when parents always ask me this, because as a parent I always like to stay on top of things, even though it's hard. But basically I think about the principles of neuroplasticity, and what is neuroplasticity? So it's the brain's ability to physically and functionally change in response to learning and new experiences. So neuroplasticity is best from ages 0 to 10. Working in that age group is great for Down syndrome because we haven't lived long, we don't have as much mitochondrial damage, and so you're essentially staying ahead of everything, especially when you incorporate laser. Ages 10 to 19, we have adolescent pruning and rewiring can also occur. We can definitely do some rewiring and creating of new neural pathways at this age, but there's more pruning occurring here. And then by age 25 to 32, you're what you got, that's what you got. Your foundation is pretty much set, your neurological pathways are pretty much set. I wanted to add that little quote, and neurons that fire together, it's supposed to say wire together.
That's okay, we get it.
Wire together. And that serves to me as a reminder also as a training therapist that for our children, repetition is key. I think for the general population, motor planning a new activity takes a couple thousand tries or 100 tries. For our kids, it's 3 times that amount to be able to gain a new skill and make a new neural pathway. So additional considerations. I wanted to add this on here because I never want parents to come to me feeling like a laser is going to cure the things that you're seeing, or that it's going to be like the end all be all. We are seeing amazing results in the community with younger kids and older kids when we use laser therapy and incorporating that into reflex integration. But oftentimes the one topic that I really hone in and emphasize is the diet, because what's happening is that laser works to decrease inflammation, right? But why is the inflammation there in the first place? This is where my practice starts to become a little more holistic, because now we go down this rabbit hole of what are you putting in your body that's causing inflammation in the brain? A lot of times it's environmental toxins. A lot of times for our kids, we have like the perfect storm kids that have the MTHFR gene, and then you put something in your body and they have a reaction. Now we have autism. Those are documented cases as well. And so the one thing that we can control is our kids' diets, right? And so in research, there is evidence that gluten sensitivities do cause cerebellar autoimmunity, and cerebellum is where your reflexes live. So if you have your own cerebellum attacking itself, we're not able to integrate reflexes. And that's exactly what happened to our son. So I shared a little bit about him earlier on, but what I didn't share was that prior to me going down researching the low-level light therapy, I had been working to integrate his ATNR for 3 years at home. We were getting nowhere. Everything else was integrated with his ATNR. And we were following a practice where they were doing low-level light therapy. There wasn't enough research at the time, so I had been maybe following them for 3 years. And the doctor had posted something that resonated with me, because he said, you have a provider working on internal reflexes for years, but nothing is happening. Why? And then he started to explain about low-level light therapy and reasons why that could happen. And so in our case, we got tested for toxins, for molds, for MTHFR, everything you can think of. And for him, it came down to he had cerebellar autoimmunity because of diet. So diet, specifically gluten, MSG, was affecting the metabolic processes in his brain, and now his brain was attacking itself. And we could not integrate ATNR specifically, because now his brain was attacking that specific brain center where ATNR lives. And ATNR, like if you remember, is the one that is correlated with diagnoses like ADHD and dyslexia, because we can't build those skills that you need to successfully do those things with a reflex that's present. So those are more citations. So those are more citations. And then the next one is just like questions. Yeah.
So once the individual reflex is integrated, does it stay integrated?
So it depends. So the first reflexes to go away are sensory reflexes. If I'm working with a kiddo and those don't go away and they're persistent, or they go away and they come back, then I know we're dealing with something else in the brain. So a lot of times, like just fixing diet will take care of that, and you don't need laser therapy. But then when they come back and they're persistent, now I'm thinking, okay, do we have like toxins in the brain? Do we have like pandas is a big one also for sensory reflexes. Once I get those to go away, then we can work on the other ones. But typically, when I do an intensive, those go away the first 3 days.
Are there things that we can do at home to know if our kids, those specific reflexes are not integrated?
Yeah, I can teach you how to test them. So for I need a model. So the first one was Babinski, right? So what you're going to do for that is I want your feet. Oh yeah.
I just said, can we use her as a model? So,
Yeah.
one of your slides said, talked about after a provider recess. You're saying nothing, because I always heard that persons, a stroke, they can go back and build back up.
So nothing new. strokes or CPUs, any of that stuff, you can regain what you once had because the connections are there. But as far as making new neural connections,
We have a volunteer.
Right, so a bit speed can happen. So I normally desensitize first by just rubbing. So what you do is with your thumb, heel outwardly. Three times. So you're seeing the response as that toes play out. Big toe goes upward. That's what I'll do. Normally when I become integrated, they'll look down, they'll go.
You said it's a positive read, meaning that she does not have. That's good.
No, it's not.
Oh, it's not. Positive means
Not
good.
major. It's not major. At positive or major. Okay, so from heel up, upward here.
On the lateral side where the pinky toe, basically. You're just kind of going up and trying to see if the toes are splitting outward and like up or down. And that's just to show that you can see that it's like not a ticklish response, right? It's going to be like a natural response that there's something that they're feeling that is not, it's not like the normal response. So like me and you, we would just be like fine with it. You know, we wouldn't put our toes up and down and splay them out like that.
So if it's integrated, your foot wouldn't like.
Well, if you're sitting,
Yeah,
sure,
if
yeah.
it's your
Yeah.
toes will curl inward.
Okay.
If it's not, they'll go out.
Yeah.
footprint inward.
For this, yeah.
How hard you were pushing that?
So for that's pretty firm push down, not immediately push down. Yeah, but then also remember before you test it, you do want to kind of desensitize the area, maybe get
You can use some vibration too,
Yeah.
or like a spot.
So, to desensitize that one, we can do like picking up marbles with your toes or walking on rocks. Desensitization with vibration is a good one also, but you should only do very little because vibration is another tool for shoulder. So I use it to break up toe, like I've seen a heel with cerebral palsy is really rigid, then I use vibration to break that up. The next one is the palmar reflex. That's in your hand. So what you're looking for, the hand has 3 nerve innervations, so you're testing. Sorry about that. So you're just gently stroking. Off. So you want to see no movement at all. You don't want to do it hard either because you have flexors of the hand over there, so you press hard, it will. So what you want to see is no movement. The next one is rooting, which we all know. So I grade. There's multiple scales for grading the reflex, and that allows me to know, okay, when do I push grading functions up higher, versus like when I have to really stay there for a while and address it explicitly. When I did it for her on the right side, she had very minimal movement. Typically when that reflex is very present, they will turn their entire head. That's a very positive read. one for Down syndrome. Yeah.
I have a question on that then. So if you've got a negative, we wouldn't know, right? So would it be like, if, I don't know, let's just say like handwriting, for instance, right? Like we are struggling with handwriting, but she tested negative for that, but we're still having issues. Would that be like mostly working off symptoms at that point?
Correct.
Okay.
She was working on
Okay.
Yeah, so spinal Perez, the opposite, so you go from bottom up, and what you're seeing is the back stiff arch. Instead of the hip hiking, the back arches the back. She already gave me a negative on that one, so. Oh, Dana, also to your question, so in my brain, I know when each reflex is supposed to go away, so if I'm not seeing it, there, then it was just the leader of that one, then I know it's also the leader.
Okay.
But then for the most part, yes, I'm working on symptoms.
Gotcha. Okay.
So for the spinal for red.
And how hard are you pressing, Josephine?
Very just gentle. Just for upper, like, a little bit harder than that, but just, yeah.
And you're using like a nail, or you're using your
Or like
thumb?
the thumb. My nail too sometimes.
Not like hard, just like a nice, because it's sensory, it's not like you're gonna push hard for pain response, it's just like just to feel that, like almost like a, not as light as a feather, but the in-between.
So in her age group, I would also test something called Landau, which is like for Superman. I didn't add that one to my slide because it's just a lot. But basically what you're doing is so you want her to go into Superman, like okay, the shoe right in her hand and then you go up.
Not like that.
So when I don't see that reflex happening, and a lot of times we don't know to the older kids, we don't have CLR, so that one for kind of feeds into that like other reflex. So you can put her on your belly and then the ability for that. Like you're making me work and towards the other. I'm gonna need alright, so 18R and ST. She did great though. Give her a round of yes. So, oh, sorry.
What was the question?
Here, you wanna?
My question is, basically, we try to find out if the child is left or right handed, if it's left or right brained, and if it's the same concept going on threads.
So I know what you're saying.
Yeah.
So when you have, so this is more like neural development, like keenness stuff, and this is where I started learning from her. So when you have that neurological foundation set, you're gonna have neurological organization. So if you're right-handed, you should be right side dominant. Hand, feet, ear, eye, all of it. So when you have that mixed dominance, it's because something at the bottom is still missing with reflexes. A lot of times with their kids also, they compensate a lot, even though they are neurologically organized, because look at their feet, a lot of them have pronation difficulties. So I know at least for my daughter, she's left-handed everything, but if I throw the ball wrong at her and she's not positioned correctly, she'll kick with her right leg.
Yeah.
So it's like one of those things that you have to keep watching to make sure. But I do address also like left and right brain hemisphere dominance like later on, after we've done like the reflex work, after we've done the vestibular stuff and the ocular stuff. Correct.
So, when we were seeing Kate,
Yeah.
she reintegrated Adriana's sensory integration stuff multiple times at different points, like as she matured and went through different things. You want to talk about that at all? Because it wasn't a one and done.
No,
It
it's
was-
not.
There was multiple times where either she got hurt or she grew,
Yes.
especially girls going through puberty. That was a big part of redoing her sensory integration. When her
Yes.
molars came in, there was another thing that she did, I think was sensory integration.
Yeah, so sensory integration is what we see as under OT mostly, like in the traditional outpatient setting, and that's just a symptom specifically related to having reflexes that keep re-emerging. So from my experience, I feel that when reflexes keep coming up, pretend we don't have Down syndrome, right? If reflexes keep coming up in a child, we're having like repetitive, like neurological insult to the brain that's happening, that's causing this to occur over and over again. So you have to keep working at it. You can work at it and integrate. So in neuroscience, when you're testing something in neuroscience, you're also teaching the test. So I've had it in the office where we're treating ATNR specifically, and it's very positive, but then 2 seconds later it's negative, but we just taught the test. So it now becomes temporarily integrated. So I think with what Christy is saying, oftentimes like with our kids, there's so much happening with their mitochondria and things shift for them all the time. I know for our daughter, like she was okay with gluten for a while, now we're not. As those things change, like that affects brain function also, and it can cause us to slow down. So we have to do it.
Yeah, I think like exposure to mold was another
exposure.
big one. I
Correct.
think if you get leaky gut,
Yeah,
that-
leaky gut.
That brain access.
Yeah,
Yeah.
that's a big one.
And also, just to mention, like, in adults and regression, so.
And David is an OT also, just
yeah.
in case anybody was wondering why he's.
So I'm an occupational therapist for like 10 years, but I've worked with adults all these years. So I would a lot of times work with adults that had a stroke. So you'd actually see a lot of these primitive reflexes coming back, because what do you do when your brain is attacked like that? You go back to your primitive brain, and you're having to get through all these reflexes again, or you can't walk, you can't talk, all this stuff is going wrong again. So that's not that we would use the same exact formula to do a rehab, but it was a kind of a part of what you would see. So anything like the mold exposure or like regression, you're kind of seeing that these reflexes might come back, and you might have to work on them again.
What about in our population, it's regression, but I think that it's regression with little r, right? Like you get high stress incidences in the flight, or, one of those symptoms gets turned on and we can't turn it off. Can we talk about that a little bit? Because I
these
think
are,
that's very
like,
common.
we're protective, right? So all these, when you're a baby, this is a protective reflex, so that Mora will, like, if you be in shock and awe, like, you're trying to protect yourself from falling or hurting yourself. So you'll go back to that as the primitive way of the brain working again.
Yeah. Okay, so primitive reflexes just starts to scratch the surface with all of this neuro stuff. Aside from assessing primitive reflexes, I also evaluate 3, like we call them brain primary areas of the brain. So it's cerebellum, right, where you first have all these reflexes, then you have midbrain, which is basal ganglia. That's made up by several structures, and then we have frontal lobe. A lot of our kids get stuck in basal ganglia, and I see this with peanuts, pandas, neurotoxin exposure also. Within basal ganglia, you have 3 loops in there. One of them is an emotional loop, because we're right there to this, we're really close to those brain centers that are responsible for emotional regulation. Another one is your associative loop, which is all your frontal lobe executive functioning stuff. And then the other one is your motor loop, so the one responsible for motor planning. So in my older kids, and even in my younger kids, when I feel like we're stuck in basal ganglia, I do range of motion testing for lower and upper extremity. Because what's happening is that will allow me to single out which loop is being affected. I can obviously see if the emotional loop is being affected, because they oftentimes have emotional outbursts in the clinic. I mean, that's good to do. But basal you often find like rigid movements occurring with regular like range of motion stuff, moving, rotation. And midbrain function is responsible for rotation of the body. So when you study neuroscience and the progression of neurological development, we really develop no different than like a lizard. We're just very like just stiff at first. They have no midbrain, so they stay stiff. Whereas we do have midbrain, and then you have that rotation coming in. So for Lucas, what we were noticing was we were running like a tin man. We're doing all of this and not really rotating movement, and so that would be something new. And I also see also with our kids.
I'm full of questions, sorry.
Yeah.
I'm the weirdo that looks at all this stuff. What about like the apraxia of the body, not speech?
Yeah.
I mean, you can talk about either one, but that's another one that I think we see a lot.
So I had one really good case in the community with this, and it was just mind blowing because when we figured out what it was, that got taken care of, and all of a sudden we're motor planning amazingly, and we're not like it was just it's amazing. So with apraxia, I would argue.
Do you want to tell people what it is, just in case?
Yes, so apraxia is difficulty with motor planning. So motor planning an activity, or we have it in speech also, where they can't, their brain knows what they want to say, but their mouth can't plan that. And so similarly, we have apraxia, where we have ideational apraxia, where you know, again, what you want to do, but you can't execute it. And then you have ideomotor apraxia. Think about the Little Mermaid combing her hair with a fork. So you use the wrong item for the task that you want to complete. Apraxia is a big thing in our kids, and I mean, I'm full of strong statements, and I'm pretty confident in this one. It's not in the literature that I know of, but I'm pretty confident that in our kids, it's basically glia. Like they get stuck there. After you rehab cerebellum, and you know you've like looked at toxins and you've looked at diet, they stuck there. And I've had cases so far where it's pandas and it's toxins, and I've also had cases that automatically just show up because of some traumatic event that happened.
And it doesn't have to be negative trauma. I think that's the other
trauma
thing.
is how you perceive it.
Yeah.
So what's traumatic for me may not be traumatic for David. And so, yeah.
Okay, show us the other,
Reflex, yes. Okay, foundational reflex, right? So ATNR, come up. Okay. So, this is on quadrupeds, so hands and knees. ATNR helps divide left and right side of the body. So you want the best alignment that you can get with legs and feet. So what you're doing is you're turning head, and you have to do it at least 3 times. Right? Middle, step. So positive read is when you're looking this way and this arm buckles. That's ATNR. So think of the skill sets that you need to be fully integrated to do that. Riding a bike, you can't turn. If you look this way, you're going to start moving around this way. Same as like STNR. STNR helps divide upper body and lower body. The same thing, look down, and up.
You're a good sport, David.
So what I'm seeing with this one is like very drastic positive.
So what would it look like if it was negative?
Show us the
Okay, so they just stay still. So you're looking for disassociation of movement, that they're able to move their head without like their whole body collapsing.
Okay.
Yeah, so that would be negative. He just stays still. Usually they just go halfway down, and it comes down to 4. So like they're so weak sometimes that they can't balance themselves, right?
The last one is TLR. So little babies, we can test this, putting her just up, facing up, and then she'll open up like this. more exaggerated it'll be. That one also very highly tied to core. That reflex is where I hang out a lot because it leads me into my next system when we do our plan with the vestibular system. A lot of times our kids have gravitational insecurities or they can't, going on like steps is difficult sometimes either because they just don't know where their bodies are at, and that's because their vestibular system is not developed or integrated. And that one plays a big role. And then the last one was moral. I don't like testing this one. It has two components, a vestibular component, so changing of head position will be indicative of the vestibular component, and then the other one is auditory. Don't like testing the auditory because but what I'm doing is I'm clapping loudly, unexpectedly, and then they start.
Yeah.
I don't like it. And then I test the vestibular component. So I used to come up from under them without them expecting me and just pull them out. And they will look, they'll do that. And then they'll look back at me and not want to hear me.
How do you fix that, like the moral instinct or whatever, is still like kind of prevalent? 'Cause like, you're going through that list and I'm like, oh god, but there's no.
So I don't want you to get in your heads about that because I feel like we can tie everything to a reflex. So just do your testing at home and all of that. So moral is a big one for our kids, and it does keep them in that fight or flight, which will affect learning. So the way that you get rid of it, I can share a resource with you guys. It's a book. It's a collection of books. Can you read it? She's an OT who has written a series of books for each reflex.
Yeah.
Yes.
Colorful,
Yep.
and they're about this big.
Yep. Yes. It gives you a couple of exercises. So when a reflex is very, very highly present, I'm explicitly doing the same motions that you listed to create that neural pathway and start to desensitize the nervous system from it. So with the moral, we do an exercise called the starfish a lot, which they open up and then close. Open up and then close. You have to watch which variation you do because not all of them are correct. The big one with that one is you want their heads to go into extension because that triggers the vestibular system, right? And this one has a vestibular component. So when they put their head into extension, they're triggering that sense of changing directions, and so now it's triggering the reflex, and now you bring them in to hug their bodies, and you're grounding them at the same time. So you're stimulating, you're eliciting it, you're bringing it up to them, like, work on it. Does that make sense? I'll share a series of books. It's a lot of information.
So, do you think you should start with one? I know you talked about that, and I wasn't real clear, that with one or my guy's older, or look for the symptoms and then try to work. What is your?
So I work on all of them at the same time, and the way that I started in my practice and with my own kids is I work on the one that's mostly positive first. I created my own scale because we were like 20 different scales to pick one. So the one that's mostly present first, that's where I start. Like what I was saying about the moral was that most of the books, like even that book series that you also had, talks about integrate this reflex first because if they're in a fight or flight, you can't get all these other ones in, but then you're going to be working on moral for 2 months. And you're losing time too, so you're going to just do just a little bit of all of them.
Okay.
What about stabilizing in the mouth? So when you do extension, and where is that in the scale?
Yeah, so that's called motor overflow. It's when they have a hard time motor planning. So the more you do it, the easier motor planning will go away, will become, and that will go away. You can also just prompt them to push.
I was just was wondering, when you put the age in there,
Yeah.
so since they're mature and sounds like age, what kind of benefits? Like we should have for I mean, you've met Jacob.
Yeah. Can you remind us again?
25, 26.
Yes. So, treatment option does change when they're older, and I think this is where we'll benefit from the low light therapy. We recently just did our first adults. And see me, and no, that yes, not you. And it's just a population I'm dying to get into because I feel like with all the research that exists with the low light therapy and Alzheimer's already, and then Down syndrome regression, there's no research. I mean, I haven't found anything when it talks specifically about regression and the low light therapy. But man, I feel like I want to do some research on that because I think it's going to be really good. So it's not that you cannot work on reflexes, it's that it's harder and you have to work for longer. Because you've already made all these connections early in his life and it's supposed to be set. However, there is new research coming up that it's still possible. So for a younger kid, we can work on a TMR for 3 days. We might have to work longer for Jacob to integrate.
So it's not impossible after 25.
It's not impossible. No. It's just.
I just want to make sure nobody heard
Well,
that.
and I think the other thing that's so important is what you said, is there really isn't the research. And I talk a lot about, I feel like our population that's in their 20s and 30s, we're really pioneers. I mean, 1980, their lifespan was 29. The research doesn't exist. So the stuff that I put a post on our family page. Those of you that are here, I'm proud of you, because really we've worked hard as a foundation to get out ahead of research, because research lags, right? So if you can be a part of it and learn from it and apply it and do no harm, obviously, but I really think what we are seeing with our 20-something plus is just stuff that is so unknown in the T21 population that, I mean, look, we have people driving and getting their 4-year degree. We have people doing Ironman, and no one would have said that was possible to us in the hospital 20 years ago. So I think never give up hope. Never give up hope. I mean, if you're tired of trying, that's a different thing, but don't give up hope. And then, with our kids, you got to just pick the thing you want to do, because we can't do it all. So pick that 1 or 2 things that you want to do. But I agree with you. I think there's a lot of hope with what you're doing in regression and Alzheimer's and plasticity of the brain that is going to be pretty exciting for our aging population, for sure.
I agree. I think one of my goals, I'm very ambitious, maybe a little bit of a dreamer, and just supports it all. But one of the things that I would love to do is get into research, because I feel like I'm perfectly positioned in our community to be able to start seeing some of these cases and collect data to publish it, because I don't think very many people know about this stuff yet. And there's a lot of existing research in red light and infrared, and it's very broad though. And so there's very limited transcranially, and then even more limited in Down syndrome.
I was not aware of, I didn't know that to be the same as interception. Can you talk about that? Because once I read it, I was like, oh my God, Sean, it was like, but it's really difficult to find stuff that is not too technical.
Yeah, so interoception is also pretty new in the OT world. Like there's new courses on it now, and it's being introduced. It's basically your brain's ability to know what your body needs. So hunger, ego, body, all of that stuff. I haven't really explored too many courses on it, but from what I know, based on like functional neurology and like all this reflex stuff, is specific to our kids. Tone. Like if their tone is very low, like they can't get that feedback back into their body and their brain to be able to trigger that. One thing I recently learned in one of the courses I took was that the frontal lobe also has a micturition center, which is your need for urination. And so we talked about the spinal gland and the spinal currents being tied to.
It was very difficult to
Yes.
And it wasn't because, I mean, we were completely dry overnight, and I knew that it was something wrong with the inside.
I've heard that a
And
lot.
still,
And we
to
did
this
it.
day, it's like, until it's like, I don't remember where.
Yeah, so what we see with our daughter is, like she never feels full, right? She just eat, so we got her food. And then also like she's potty trained and everything, but we will wait very last minute and then it happen. So that's immaturity. I would argue that that's immaturity in the Victorization Center in the frontal lobe, and we're not able to inhibit that and really like feel it. So I'm actually I'm experimenting with her because I started lasering that brain center to see what would happen with that.
Yeah, I just want to, like I said, I thought when I first read about it and heard that they put on it, I was like, oh, that's it. But then trying to find
Yeah, I want to say that.
about it or how to,
Yeah.
it's like,
Right.
Where does impulse control land?
OCD tendencies, basal ganglia.
What was the last thing you said?
Basal ganglia. Yeah, and it gets inhibited. Everything gets inhibited.
Did you show how to test that?
No, you can't test that. That's so it's patient report, and it's well, you kind of can. So this is the area that has the 3 loops.
Okay.
One of them is like we're testing rotation. So you want smooth movement. If you're feeling like this, then that's center.
So when you answered her question about the food, you were saying the shut off balls for your daughter. Is that the same thing as what you were saying, or is that a different?
So similar with interoception. So it's tying it back to interoception, which is like your body's ability to be able to feel hunger, or cold, or all that. I want to say that under like the OT lens, knowing how the OT world runs with interoception, they mainly teach strategies to kind of stay ahead of those things. Again, I don't know. I haven't taken any specific courses to that.
but it was like, just like he'd be in the pool when he was a kid, and his lips would be turning blue with your cold, I'm not.
That's what I'd say, the cold is one.
Yeah, the cold.
Not knowing that they're cold is one. Not, some of them, yeah, some of them not, there's not very many.
Not
You have a special one.
So when it comes to
But yeah.
temperatures, that's regulated in the brain
Pain,
stem.
that was the other one, the high threshold for pain.
Yes. Yeah. So I just one of the areas that I'm trained in is with Moscatova and MRI techniques, and I would argue that neurotactile work is very important for our kids, just because of the low tone. So you're providing that feedback into the brain, which is starting to elicit or allow the elicitation of these reflexes.
So we're just like, if they went home and worked on just deep pressure first, if you want to talk about that.
Yeah. So with neurotactile work, what you're doing is you're providing deep pressure to the body, but in a specific way, just because we have different receptors in different areas, and so this is all feedback back to the brain. So.
So what you do is always start away from the body, and when you do to one side, you do to the other. You'll start, our kids don't feel like you usually have to go hard, and you start by pinching really hard at each of the joints. So joint, so bone, joint, bone, joint, bone, joint. So you squeeze the bone, 10 seconds, squeeze the joint, and you follow that all the way up, and then palm, you do at the same time. Squeeze, you let go, and then when you get to, this is the first joint, then you will stretch. So you're stretching to where you see the skin pull apart.
So good to do with your little ones, so those of you that still have little ones. This, so good.
For me, I noticed that I have to do it all this, because otherwise we're just like, we just don't know our
And some of them actually like it. I used to do it to my kids like in church.
Yeah.
And even now sometimes when we're like, and my kids are 22, 18, and all I used to do, and they would just sometimes they'll just put their hand there and be like, they'll like nudge me because they want me to like do this on their fingers.
That's it, yeah. Adriana wants me to do it when she goes to bed. She likes, it organizes their brain. But she'll be like, will you tickle me but finish with squeezing me?
And this is the second time when you also a lot of times our kids will listen, you won't feel the joy, like kind of gentle. But I don't do the shoulder because it's only because we don't. And then you do other arm the same way, and then toes. You stretch at the ankle and the knee, and you squeeze all the way up. And then when you get to torso.
Squeeze them.
Can you stand on one foot and touch your
And then oftentimes I don't, in the head, I like it, but I don't like it because what I know with, also training cramps in the face. So what I know with that, I know I shouldn't be pushing on the structures too much, but it helps their vestibular system calm down, so.
It feels good though, if somebody
It
does it.
does, and I have kids that are actively like stemming, or like, making noises, or, and I do that to just ground them. Good, for 20 minutes at least, and then we move on. Yes, with the vibration, like I said, I use it for the sensory reflexes, but you wanna be careful with how long you use it for, cause it numbs the central nervous system. You don't want that, so essentially, with low tone, they don't feel as well, so by numbing the central nervous system, you're gonna be doing something.
So what about the vibration plate?
Yes, so the one that I
I have a
use.
million questions.
The one that I use in practice is gonna open another rabbit hole. Okay, the one that I use in my clinic, vibrates at specific frequencies. The next thing that I'm researching right now is oscillations in the brain. So we have these brain waves like gamma, beta, theta, all of these. And so these are all oscillations, so that means like the specific frequency that they vibrate is what shows up when we do these tests where we see these brain waves come out. You're right. So the vibration plate that I have in the office works on gamma wave activation, which our kids need for attention. A lot of our kids have terrible postures because we have these reflexes, right, and our core. These gamma oscillations are in frontal lobe, but they originate in spinal cord. So if we have this posture, we're not effectively right.
I'm bringing you Adriana.
Right.
Give some good on it and you.
There's a video. I put a video where, and so a lot of reflexes are very dependent on vision, which is why I use vision a lot to inhibit and integrate. Because with vision, if we're sitting this way, our vision only goes as far. And then the minute we fix that posture and put them into that more like posterior pelvic tilt, makes them go up a little bit more, and we get better.
Well, that also does with their relaxed hips, right? Like
Correct. Yeah.
How do you know if you have a gamma one or not?
A gamma one. So 15 megahertz is the frequency for that. The ones that I found on Amazon, they're not gonna be that. There is one on Amazon that I purchased it for $7. The one that I have in the clinic. But the ones that are used generally are more for like lymphatic drainage, and honestly, I feel like those are a little bit too rough. I put Mila on it once, and I did a slow-mo video, and her head is just jerking all over the place. And you know, with the instability that they may have, I don't know, so I felt about bringing that into the clinic, so I'm investing in that one.
So what is therapeutic with that, with different brain?
Yeah, I'm not too familiar with that program. I know a lot of them use it. So I couldn't use this.
We have the close to you, but this way is that you can totally visual, is that helpful? Visual
the carries is, is it better for them to be facing like you, or better for them to be like facing me? Is there a difference?
Oh, got it. Oh, but okay, definitely facing outward, just more visual input stimulus.
Can you share your slideshow?
Yeah.
Because I couldn't write as fast. Right, you got a really, a lot of good information. Because
A lot of times when I do my emails, like I know this is a lot, so I send the full report and this information on each reflex is on there, so parents can refer to it, because it's a lot.
Did you say the name of the book?
It is,
But there are multiple books, so like,
they're called, Integrated Primitive Reflexes Through Play and Exercise. It's by OT, her name, I'm gonna spell it out, K-O-K-E-B, McDonald.
K-O-K-E-B.
Her first name is K-O-K-E-B. K-E-B. E-B.
And then
Integrating primitive reflexes through play.
yes.
so there, it's mostly gonna show you all the exercises that you can do to integrate that specific reflex. So like, it's a series of different books that, you know, like it's kind of color coded this. So this one's like, for example, the moral reflex, it's, yellow book. So you'll see that's one of the first ones you might want to integrate. You might want to do some of those exercises. But you also might want to do other ones for TLR or ATR, and also start integrating those. And through like, what we do is with laser and with the exercises. So like you're integrating both at the same time, so that that area of the brain is going to be integrating that reflex all at the same time.
Yeah, so we stack interventions. I taken every reflex course you can think of. So I started before even being an OT through his CEU certification course thingy, taking all these reflex courses, but I couldn't do it on Lucas because I wasn't finding anybody that did specifically reflexes locally. And since then I've done MNRI training, which is Moscatova. I've gotten certified for it also. And then I take from every course and I learn and I put it all together. Because oftentimes what you're gonna find is a provider that really just believes in this one thing, but then you're really missing out on what others can provide. So I just mix it all, and I stack interventions out.
Any other questions?
Can you give an example of how you use laser while you're doing something?
Yeah. Yep. So I create my own
No, but she's
protocols.
saying you're stacking things,
Yep.
so, I mean, I'm assuming you're talking, well,
Yeah. So stacking a therapeutic intervention, so like what OTs would normally do without laser, and then just adding laser to it. It's like using laser therapy in our practice is like the perfect marriage between functional neurology and reflex work for OT. You have to really understand brain neuro to see how you are going to target and develop protocols. So I develop protocols for each of my kiddos based on my initial eval. So if I'm finding a specific reflex here, I'm lasering areas that feed into that area and then targeting that area where that reflex lives, and then following it up with frontal lobe work to make sure that we strengthen that area to inhibit it. So a lot of times with Down syndrome, the first area I'm rehabbing is cerebellum. So we do a lot of core activities first while we do lasering. So I'm literally holding the laser while we're doing the 2 minutes, 2 or 3 minutes, depending. It's calculated dose for each child also. And then that gives me the best results. If I have a kiddo that's like really moving a lot, I give them all a break first. We have a ball pit in my clinic that everybody loves. I let them sit in there, laser them, and then we get to exercising. Because now I've provided the brain with the energy it needs to be able to complete or have like better just motor output for what we're trying to achieve. Does that make sense?
I have a video.
Well, thank you for being here and sharing your knowledge with us. I think we all can for sure learn something new tonight. Thank you very much.